Hey, Rich, thanks so much for joining me on the Journal Club this week. You've picked one of your own papers, which you wrote back with a number of very esteemed colleagues back in 2019 on patellofemoral pain or kneecap pain. Tell me about why you did that review paper in the start.
Well, thanks for having me, Randall. This is a real pleasure to be on here, and yeah, thanks for letting me talk about this paper a bit. Yeah, this is what's called a clinical practice guideline, and what a clinical practice guideline is supposed to do is kind of just like that. It's basically summarizes the literature and provides theoretical and clinical and evidence-based framework for clinicians to try to provide some standards of care. It's not necessarily prescriptive, but it's saying, well, this is what the evidence is suggesting would be the best way to either evaluate someone or to treat someone. A big reason for that would be like, if, for instance, if someone were to have a heart attack like in Melbourne versus I live in Montana in the United States, you would expect that if you go into the emergency room that you're going to receive basically the same level of care, the same type of care with some variation. Physical therapy can be a little bit different. You might go see a physical therapist in town for patellofemoral pain or kneecap pain, and then you might go see another physical therapist on the other side of town, and you might receive two totally different types of physical therapy care. And so that's where guidelines come in. And I should say too that guidelines are also in other areas of medicine and healthcare, so they're not unusual. They're well accepted, and so they're supposed to be very concise guidelines that not only do they provide provide recommendations, but they also provide grades of recommendations. So how strong the evidence is, and that can help a clinician or a patient understand how serious they should take these recommendations.
I think you did some great work, and it's very easy to read. And as a clinician, it does give you a very nice framework to help treat people with kneecap pain, patellofemoral pain. One thing we spoke about just before we went on air was some of the risk factors that people can have to develop patellofemoral pain in the first instance. So, talk to that. What people get patellofemoral pain?
Yeah, I think that understanding who the typical individual is who might develop patellofemoral pain can really help us develop injury prevention programs, and it can also help guide our treatments as well. And one of the things that we found with the more that we looked at the literature, we found that some commonly held beliefs when it comes to risk factors don't really pan out. And so, for instance, it's widely thought that people who are taller, people who have a higher BMI, a higher body mass index, people who have weak hips, or people who have certain alignment or structural things such as that they tend to overpronate. And it's often thought that those individuals are at greater risk for developing patellofemoral pain. But there doesn't really seem to be a lot of evidence for that. And that's actually a really important thing to consider, because as we as healthcare practitioners or patients or just the general public, if they're thinking about starting an exercise program and perhaps they are a little overweight, oftentimes they'll be very worried about developing knee pain. And I think that that's kind of a societal expectation that you weigh a little bit more and you might develop knee pain if you start exercising. So it ends up being a barrier for that person to start an exercise program. And so I think it's really important for us as clinicians to say, there doesn't really seem to be a lot of evidence saying that because you could lose some weight, that is going to set you up for knee pain. And so rather, the thing that seems to set people up for developing patellofemoral pain is if you make a really rapid increase in your training load. So if you suddenly start doing an exercise program and you haven't been doing anything, or if you have been exercising at a certain level and then you suddenly ramp up how much training volume you're doing, or maybe change the type of training you're doing. For instance, if you're a runner and you're running inside on a treadmill, and then instead you decide to go outside and run a lot of hills, that's going to be a really easy way to increase your overall workload. And that seems to precipitate the development of patellofemoral pain.
And I'll ask you two things here, Rich, sorry, just to jump in. Is there can you quantify that in any way? Like people will say don't do too much, and that can be subjective depending on what your mindset is at the moment. So, and also changing things. So if you take your research hat off and you put your clinical hat on, and people say, listen, I want to build up to a marathon, how hard and how fast can I progress? What's your answer to that?
Well, I think that's $1 million question right now. And I think everybody's trying to figure that out. And I think that, now with the the popularity of wearable devices such as GPS watches, and you know, even if you just run with your phone, it'll track your overall running load. So it seems like we're getting to be very, very good at measuring things, and as far as like determining what those measurements really mean from an injury prevention standpoint, I don't think we've really gotten there yet. And so I know a lot of people are working in this space, and we are as well, just trying to understand what is too much. And I think that probably is a little bit different for everybody. And I think that there are a lot of things that kind of go into someone's risk of developing patellofemoral pain. And when you think about, like, you know, that those underlying risk factors are basically, I don't know, the gunpowder, if you will, and then that training error is going to be that somebody lighting the fuse, and that's going to cause that injury. And so I think that those things are going to be different for everybody. And I know for me, I mean, I'm in my 40s now, and I think that I can't get away with certain types of training that I could earlier in my life. So I think that these things change, not even, you know, just, you know, across different people, but also within the same person across the lifespan. But I think also other things can really influence this too, as far as like how stressed you are and how much sleep you're getting, and some of the other things that we're starting to gain a better understanding that seem to precipitate some of these injuries. So, you know, for instance, I know that's really a widely held belief that if you increase your running volume more than 10% per week, that is going to be a risky amount of running. But it seems like some people can get away with that and others can't. And so one of the things that we do know is that novice runners, for instance, that they can't get away with making such big jumps in their overall running volume, whereas someone who is an elite, someone who's had a really long history of training, they can experience greater fluctuations in their overall training load without developing an injury. And the number one injury that runners get is indeed patellofemoral pain.
Great. That's some terrific insight there. Now, in your paper, we're just going to move on to some of the interventions and the therapies that are used for people with kneecap pain. And in the paper, you did another excellent job of actually rating it on evidence. So you gave an A for things that had extremely strong evidence base behind it, all the way down to an F, which was essentially just kind of expert opinion. So that makes it very easy to understand where the scientific literature is at the moment. The strongest evidence by far, what it seems, is exercise therapy. So for people who have got patellofemoral pain, kneecap pain, the number one thing is to do some exercise and some strengthening exercise to help support the kneecap and the joint. Is that correct?
Yes, absolutely. Yeah, and it should be, you know, I think it's really important that every rehabilitation program for someone who has patellofemoral pain, the foundation of it has to be exercise therapy. Now, you can do some other types of treatments in there as well, but if you have patellofemoral pain, for instance, just going and getting a new pair of shoes, getting some other kind of standalone treatments that we would consider to be like nice to do, like maybe manual therapy or something like that. This is not going to lead to a lasting improvement and recovery from patellofemoral pain. Exercise therapy is really the name of the game when it comes to structuring someone's rehabilitation program. And when we look at exercise therapy, the thing that's most important is that it involves quadricep and hip strengthening. So you should be doing exercises that are coupling, exercises that load the knee and also exercises that load the hip. And ideally, you're doing both of those at the same time.
There's another one in the paper, which is patellar taping. So I'm old enough to be back in the old school where Jenny McConnell's patellar taping was all the rage back in the early 2000s, and it works. Like, I mean, there's you guys gave it a B grade evidence for that. But the thing that I found interesting was that bracing was deemed not effective. So what's the difference between taping and bracing, and why is there the conflict in the evidence?
Yeah, so I think that's a fascinating finding, and I think it should give a lot of us some pause when we take a step back and we start to kind of maybe critically examine or analyze some of our preconceived notions of what causes patellofemoral pain and what someone who has patellofemoral pain looks like. So patellar taping, as you mentioned, it improves symptoms, but it's not helpful as a standalone treatment. So you have to couple it with exercise therapy. So we'll kind of get that out of the way. But patellar taping, it doesn't seem that it has to be quite as tailored as perhaps what you and I learned. I think Randall, I'm guessing maybe you and I are probably the same age.
I think we're close.
Was a PT. I started being a PT in 1999, and so I also learned how to do tailor taping and some of the other techniques from Jenny McConnell. And it seems like we probably don't have to be quite as picky with the way that we're applying the tape. And the big reason for that is that taping doesn't seem to change alignment of the patellofemoral joint. So it might, when you're on the table, you can put a piece of rigid tape on there and it looks like it's shifting that person's patella. And the problem is, as soon as they stand up and they start doing something that results in or requires a lot of quadricep force, that patella basically just goes right back into where it wanted to be anyway. And the reason why that's important is because we used to think that that patellar maltracking, or if your kneecap was tracking laterally, that was a big cause of of patellofemoral pain. But it doesn't seem that that's really the case. So it doesn't seem that like alignment of the patellofemoral joint sets somewhat up for patellofemoral pain. It also doesn't seem to be able to identify someone who has patellofemoral pain. And the nice contrast to that is patellofemoral joint bracing. So like a lateral buttress brace or some sort of brace that has the strap that's pulling that patella medially, that definitely changes patellar alignment. And we see that before the person contracts their quadricep. And then once they stand up and they start doing squats, and we see that with these dynamic MRI studies that shows that a lateral buttress brace changes patellar alignment as long as you're wearing that brace. And the thing that's really curious is that patellar bracing doesn't seem to result in improved outcomes with people who have patellofemoral pain. So we've got an adjunct that doesn't change alignment that seems to improve outcomes. And then we have another one that seems to that actually changes alignment that doesn't result in improved outcomes. And so when we think about that, we're starting to say, well, maybe some of those things that we used to think that patellar maltracking is not quite as important. And when we take a step back and we look at those MRI studies that are looking at people who have patellofemoral pain, we also see that this is even without a brace or without taping, we see that you can't identify someone who has patellofemoral pain just by looking at an image. And so that makes us feel pretty good about just sticking with taping. And when you think about it too, that's nice because, brace is kind of heavy and it can be difficult to put on and they're not awesome to wear. Taping can be a lot more portable and it's a lot easier to apply as well.
Is the takeaway maybe that it's got to do with not alignment and strength, and the taping potentially kind of can increase the neuromuscular activation of the quads particularly? Why does taping work is the question.
Yeah, I don't think we know the answer to that yet. And it used to be thought that, patellar taping was going to improve the contact area or that footprint between your kneecap and your femur, but it doesn't seem to do that either. And so it might just be the tactile stimulation of this rigid piece of tape across your skin that it's maybe causing some sort of distraction to your nervous system. And you don't, and then you're not focusing so much on your pain. Your central nervous system is processing those inputs a little bit differently and you're not sensing pain. And the reason why that's really helpful when it comes to treating people who have patellofemoral pain is that if they're not experiencing as much pain with patellar taping, then you can load them up with more resistance. And we know that the heavier that you load people who have patellofemoral pain during their strengthening exercises, so they're doing heavier weight on a knee extension machine or heavier weight with a leg press machine, that they're going to have a faster and a better recovery from patellofemoral pain. And when we look at patellar taping, it seems to have the biggest effect in the first 12 weeks. So that's when we really want to be doing a lot of taping. That's typically when people are going to be the most irritable. And I think that's one of the reasons why it seems to be the most effective.
Foot orthosis was also in there as an intervention. Got an A, very effective. So what's happening there as well? We've just been talking about maybe the bracing changes alignment, but it doesn't change the pain. Is it a similar story with the foot orthosis as well?
Yeah, exactly. And in fact, if you remember earlier, I mentioned that foot pronation or having a flat foot doesn't seem to predispose someone to patellofemoral pain as we once thought it did. But interestingly enough, using a foot orthosis seems to result in better outcomes, both 6 weeks and 12 weeks, and also even 1 year out from the onset of physical therapy or the start of physical therapy for someone who has patellofemoral pain. So interestingly, you don't have to use a custom orthosis. You can use an over-the-counter orthosis, and you're going to get the same outcomes. So just a really inexpensive in the United States, where you can get them for about 25, 30 US dollars for an over-the-counter orthosis is going to give you the same outcomes if you buy a $300 or $400 custom foot orthosis. And when you look at it, there's been some really nice work that Mark Matthews did as part of his PhD. And it used to be thought that if you had a more flexible foot or a foot that tends to pronate a little bit more, that person's going to do better with a foot orthosis. But they've shown that that you can't really predict who's going to benefit from a foot orthosis. So what we do in our clinic is we have people do a single leg squat with and without a foot orthosis. And if the foot orthosis seems to reduce their pain during that squat, then we'll go ahead and stick with that for the first 12 weeks or so of the rehabilitation. If it doesn't seem to make any immediate reduction in their overall patellofemoral pain, then we just move on without it. And we do the same thing with patellar taping as well too. If you don't get an immediate reduction in pain, it's probably not going to be the adjunct for your patient, and you just need to move on and try to find something else that might work.
Some of the passive therapies that a lot of patients and clients will come in for, saying, can you please rub this out, or can you please dry needle me, or can you please get some machines on there or take the pain away? They don't work.
Yeah, they don't work either. So ultrasound doesn't seem to result in improved outcomes for people with patellofemoral pain. Dry needling doesn't also. So you can dry needle all you want. It doesn't improve muscle force production, and it does not improve patellofemoral pain outcomes. We also know that manual therapy does not improve either. So if you're doing patellar mobilizations, or even sometimes you'll see published people doing lumbar manipulations for people with patellofemoral pain, that also does not result in better outcomes for people with patellofemoral pain. Electrical stimulation does not either. So doing a lot of electrical stimulation to someone's knee, your time is much better spent doing exercise therapy than having someone do some sort of passive treatment to your knee. So yeah, as you mentioned, just rubbing a knee and doing some of those other things, it might feel good at the time, but it's not going to really make things better. And it's not really going to improve how fast you're going to get better from this injury. So yeah, it keeps coming back to the same thing: exercise therapy and whatever you can do. And that's typically going to be patellar taping and a foot orthosis that allow you to load that patellofemoral joint a little bit more with more weight. That's going to result in better outcomes.
You published this paper back in 2019. We're speaking in 2022 now. There's a lot of water under the bridge since then. If you wrote this paper again, is there anything else that you would include that was omitted from the last time you wrote this?
Oh yeah, well, that's a great question. So there have been a couple papers. Well, for instance, that foot orthosis paper from Mark Matthews that I just described has been written since this guideline came out. And that, I think in the guideline, we say that people that have a flexible foot would benefit from a foot orthosis, but that's now been shown not to be the case. And that was a very large randomized control trial, and it's very well done. So I feel I have a lot of faith in that study. So it doesn't seem that foot type really predicts who's going to benefit from a foot orthosis. At the time that we published this guideline, there was one paper that looked at blood flow restriction training, and that was done by Lachlan Giles at La Trobe University with Jill Cook. And what they found was that individuals who have more painful knee extension seem to do a little bit better with blood flow restriction training, at least when it comes to improvements in strength. Their overall outcomes don't seem to really change either. And since then, another blood flow restriction training paper has come out with people who have patellofemoral pain, and it found something very similar. It doesn't seem to result in this like massive improvement in outcomes, but it does seem to help people gain strength a little bit faster and a little bit earlier than that. So other papers that have come out that have been that I think are probably noteworthy. I think that some of the work out of Denmark from Michael Rathliff and Sinead Holden has been really quite remarkable. They've been doing a lot of work with adolescents who have patellofemoral pain. And what they're finding is that the treatment for people that were for adolescents with patellofemoral pain should look a little bit different than adults with patellofemoral pain. And for adults with patellofemoral pain, you kind of want to get in there right away and start doing a lot of strengthening with them. And whereas with adolescents with patellofemoral pain, there probably should be a more of a period to try to get the knee to kind of settle down, and where you're actually working on just really controlling workload and loads on that patellofemoral joint. And I think that's important too, because when you look at taking a step back and looking at some of the risk factors for the development of patellofemoral pain, particularly in adolescents, one of the biggest predictors that's coming out now is sport specialization. So if you're playing the same sport year round, that seems to increase your risk of developing patellofemoral pain by 50 to 75% over an adolescent peer of yours. So this idea of controlling workload in the adolescent seems to be really important, because that's a time when a lot of teenagers are being involved in different sports and they're practicing a lot, and it might just be a little bit more workload than what they're able to tolerate. So there's that. And then I think the other really important paper is that changes in hip strength when during the recovery, and this is another paper from Michael Rathliff and Sinead Holden, is they're finding that doesn't seem to predict who's going to recover from patellofemoral pain. So in other words, the amount of strength that you gain in your hips during rehabilitation doesn't seem to really be a controlling factor in how quickly you recover or how much you recover from patellofemoral pain.
All those papers that you mentioned could definitely be a podcast on their own. And I'm definitely going to get you back, Rich, and I think we need to dissect this just a little bit further, but we're out of time today. So I'd like to thank you very much for coming on the Journal Club this week.
Thanks, Randall. It was a pleasure. Thanks for having me.